Welcome back to Stop Feeling Like Shit. Today, we're diving deep into the importance of estrogen metabolism with a powerhouse guest, Dr. Brooks from Dutch Test. Estrogen plays a crucial role in everything from mood and metabolism to bone health and brain function. But how your body processes and clears estrogen is just as important as how much you have. If you've ever struggled with hormone imbalances, PMS, weight gain, mood swings, or stubborn health issues, this is the episode for you. It's packed full of actionable insights to help you take control of your estrogen health. Let's get into it. Welcome to the show, Dr. Brooke. How are you?
Hi, thank you. It's exciting to be here. I'm Dr. Brook Ahnemann. Dr. Brook is how I prefer to be called. I'm a naturopathic doctor. I've been doing this for a little bit over a decade or so now. I've always had an interest in whole body health, nutrition, herbs, lifestyle, and so kind of headed into naturopathic medicine, and then really specialized in women's health while I was in school and then in practice, which then led me over to Dutch, where I really get to focus in on hormone health, which is really exciting, and I love it. I love getting to talk to all our practitioners every day.
Yeah, and I love that because, in our clinic, basically, we do a lot of the Dutch test.
Yep. So what really sparked, and Tiffany's not here with us today. So our office, we do a combination of, we do some medically assisted weight loss, but our big meat and potatoes is hormone replacement and then functional medicine. We do a lot of both of those. And obviously with hormone replacement and functional medicine, the paths cross a lot.
Mhm.
But what we found, myself, Tiffany, and Dr. Bainan, is that with just HRT, although it's great, is there was a lot of misses in care. And we were finding with serum only blood testing that there were some limitations to all the things we could do as far as correlating symptoms and labs. And there's pieces that were missing. Where we're really fine tuning and figuring out our patients. We knew that there needed to be more to what we were doing. Um, and I've been familiar with the Dutch test for a long time because I've been in this realm for about 15 years, but we got real familiar with it, I don't know, maybe started seeing them more maybe 4 or 5 years ago. But when we decided to add it to our practice, we felt like it really has opened up uh, case management capability and help us differentiate our practice, but really helped us as far as quality of care, especially with our female patients. Because once you dig into this test and everything else, as you know, it's so much more complicated than you can just get from serum values. So,
Yeah, and that really gets into the difference. And one of the things I love about Dutch, we often say Dutch gives you more of a 3D view compared to serum or even saliva. Like both of those, you get a picture of the hormones that are in circulation and production, and that's great and gives you one level of view, but it's also a single point in time, right? So, and hormones fluctuate, as we all know, both like for women throughout a cycle, but even throughout the day, they can really jump up and down. And then on the Dutch test, you get that extra level of like, you get to see more of like a 24-hour picture. So the average tissue exposure over a whole day, because you're doing several samples at home, nice and convenient, which a blood draw, not always so much. But you also get not just the production kind of levels of like what are the circulating hormones, like our estrogen, progesterone, testosterone, but you get the metabolism, like how are the tissues using these hormones, clearing them, and that can make a really big difference in the short term for symptoms, but also in the long term for like preventative health, which I think we all in the functional world really work on as well.
yep. And that's kind of what drew us to the test is we were having patients where serum values or even salivary values may look really good, but a patient remains subjectively symptomatic. We said, well, there's a miss somewhere in care, and you don't want the answer to be, well, let's just try stuff, well, let's just throw some things at it. Let's throw, it's well, let's bump progesterone, even though the labs say that you don't really need to, or let's see what DIM does, which works on one specific pathway, but may not be the right one. So from a troubleshooting standpoint, I mean, it's just such a valuable tool for us in practice. And I like how you described it because when I'm talking about the test to patients, I always tell them, the blood test kind of tells us what's on the highway, tells us what's
Yep.
circulating. This tells us more what's happening from a metabolism and a tissue exposure standpoint, which subjectively, metabolically, and then from a health management standpoint is almost clinically more relevant to what we're doing for care.
Sure, sure. And those
And I don't
metabolites
think
are
I've,
still active. Yeah. Oh, sorry.
sorry, I don't think I've also ever have heard of somebody doing a saliva hormone test.
Yeah.
So what's the difference?
So saliva in some ways is similar to serum. It's a single point in time, right, of like one collection typically. And it's great for cortisol. Like that's where you see it most of the time for like adrenals. But for like sex hormones, you'll see it there as well, but not as validated. And it's really looking at then like more of salivary tissue exposure, right? Because it's coming through that particular like gland. So, and other than just the like the medium that you're like gathering, like serum, saliva, or urine, the type of testing like that you're doing, which often is immunoassay or LCMSMS, like liquid chromatography mass spectrometry, makes a big difference. And saliva, you often see more immunoassay. So you have these really big ranges, which can be hard then to know where your patient falls. Like, is that an appropriate range or not if the range is very broad? Whereas serum, you'll see both immunoassay and LCMSMS, the more specific. And then on the Dutch, that's what we're using is the much more specific LCMS testing. And so you get a very sensitive test that can also detect very low levels of hormones, which again, in immunoassay, you don't get to see that. So that's kind of some of the differences. It's not just what you're testing, but how you're running the test that can make a big difference as to how specific and sensitive that test is.
Hmm. Okay, that's great. And so I guess like explain to the audience that are listening, the important process of like what does estrogen regulate?
What doesn't
Yeah,
it regulate?
yeah.
Right? The list is huge. Like typically, I think the most common thing we think about is like reproductive health, right? Fertility, reproductive organ development, breast development, but certainly bone is probably the other thing that people think about, like bone health. We're starting to talk a lot more about cardiovascular health and brain health, but metabolism, it's got a factor in that. Factor in connective tissue, so like joints and skin, mood. So, I mean, really, it's got touches all over the body.
It's
And
important.
it's important to know too, I think a lot of guys think they want no estrogen.
Yeah.
Oh
Yeah.
no,
So,
they need some estrogen too.
yeah, so you hear from guys, hey man, I want my estrogen all the way down. They don't understand that males need estrogen too. It's not a bad thing, right?
Yeah, I hear men want to take estrogen blockers all the time.
Yeah, it's weird. It's usually one extreme or the other. It's either men, they're like, I don't want any estrogen, right? I want none. I'm like, well, that's definitely not true. You don't want osteopenia or Alzheimer's or anything like that.
Hmm.
So you do want some, and then the other end, you'll have some guys that think anything that may slightly reduce estrogen is the worst. So it's always one extreme or the other, which is not atypical for a lot of things with our male
Yeah.
patients. But
Yeah,
Yeah. And
so
I think
you
it's, oh, I was going
go
to say
ahead.
for like men and for women, I mean, you want a little bit, like you want an appropriate amount. Nobody wants too little or too much, right? Because either end of that spectrum and extreme, you're going to end up with like symptoms and kind of long-term effects.
And do you want to describe the three primary estrogen metabolites?
So I mean, we have our parent estrogens, right? Like the estrone, estradiol, and then sort of like estriol. That one's so those are our like actual hormones that we're producing that the tissues are seeing. Estradiol being the most potent and the one that's most common like through our reproductive years. Estrone is more predominant postmenopausally, and then estriol is really like the estrogen we see most in pregnancy. From there, each of those, well, are really the parent ones that we mostly talk about are estrone and estradiol. And from there, each of those are metabolized primarily, like, and on the Dutch, what we're looking at is three different pathways, like in that phase one detox, to move down to like a 2-hydroxyestrone, a 4-hydroxyestrone, or a 16-hydroxy estrone, or and then estradiol moves down those same pathways as well.
And what's the difference between produced versus metabolized estrogen?
So produced is like when we're talking about that, that's what like the glands, like the ovaries are making in the body. So there's somewhat of peripheral like fat tissue and things that can be making a little bit, but for women, most of it's coming from ovarian production. So that's what is produced moves into circulation, right? And that's like when you get a blood draw, that's what you're checking. From there, though, it's headed to all these tissues and popping onto receptors and getting utilized by the body and metabolized. And that's then what we're looking at in urine is those metabolites. So that's why it tells us how the tissues are using these hormones and what's getting cleared by the liver.
Yeah.
Wow. It's so interesting to me. And I was on bioidentical hormones and I had a lot of issues going on and I felt terrible. And then we did the Dutch test on myself and I learned that I wasn't clearing estrogen, correct?
Mhm.
Yeah. So what we saw with Daniela is on serum values, her estradiol specifically wasn't particularly impressive. It was bottom, quartile, bottom third.
Mhm.
But when we did the Dutch, I think we saw it, and I may be speaking, I'm speaking from memory, and I'm not saying that's super solid. But she had a lot of weird estrogenic symptoms, right?
Mm. Mhm.
Um, where downstream, so that CYP3A4 pathway was kicking a lot of estradiol to estriol, and then
Mhm.
she was creating a ton of 16-hydroxyestrone, and what
Mhm.
was going down that 2-hydroxy pathway was almost non-existent. So we saw, part of that enzyme family was overactive, and then that pathway of glucuronidase clearance was extremely poor. So that was a case for her where, and we see that with a lot of patients
Yeah.
where they have these weird estrogenic or almost estrogen dominant symptoms that don't present estrogen dominant on serum, right? But then we
Yep.
see downstream like, oh boy, you may not be making a lot, but it's hanging around, and the metabolites you're forming are really not the ones we want.
Yeah, and that's the problem. Those phase one metabolites, so that first round of clearance, all of those metabolites are still somewhat estrogenic. And so that's if you're moving a lot down one of those pathways, and especially one like that's suboptimal, you're going to like are adding to your total estrogen burden, right? And that one, it sounds like that for Daniela, that was moving like that her estrogen's moving down that CYP3A4 pathway, that 16 hydroxy is particularly of the three the most estrogenic and proliferative. So we see a lot of symptoms like the breast tenderness or mood swings, even and migraines. When women are cycling, a lot of heavy bleeding, fibroids kind of associated with that metabolite. So there's a lot of times we'll see normal estradiol levels, but we've got all these like estrogen dominant symptoms, and it's not a problem of estrogen production, it's a problem with estrogen clearance.
Mm. Wow. I think this is so interesting to me. And so I just I hope the audience, if they're listening, they can understand what we're saying because I'm over here like, I hope they get what we're saying because some of these words I don't know that they understand.
Yeah.
So what do you
Yeah.
feel, I guess if you can just talk to us, just the Dutch in whole and with estrogen in whole and whatever you feel like people need to know and learn about this test and what it can do for them.
Sure. So, I mean, it gets to give you, like, again, this like robust picture, not just of your hormone production. So, and that can be important because a lot of times we want to know what is our actual level of like androgens, testosterone is what we think of most there, or our levels of progesterone, or our levels of progesterone compared to estrogen. But again, there's this next level where we can have very normal production levels, but how we are clearing those, like how the tissues are seeing those hormones, can be affecting our symptom picture. And then again, our long term health. So some of those phase one, like first round of clearance metabolites, like can cause symptoms, but some of them can cause long-term like health issues or maybe have an increased risk of like cancer associated with them. So we get really picky. So that's where like we can fix both short-term issues and optimize health long-term and go through. And so that's when we talk about detox and like this estrogen clearance to kind of like do it in more layperson terms, it's like we're taking out the trash, right? Like, how do we clear things? And it's a multiple step process. Like, you've got to like clean up around your house, you put it in the trash bins, or you put it in the recycling, or you put it in the compost, and then you've got to bag all of that up. And so there's like the first round, and then you bag it up and get it ready to go round two, like phase two clearance, and then you've got to get it out of the house, right? And that's phase three elimination. So all of them are important. On the Dutch, we primarily are looking at that first and second phase of clearance that can have a big impact on, again, symptoms and long-term health. And that's what it's so for a lot of people, they test because there's symptoms, but there's certainly people out there that are testing preventatively, maybe have a family history of cancer or just want to make sure before they go on hormones, they can be preventative. So it can be helpful really for all of us.
Yeah. And what influences these pathways more or less? And we already know that, our environment, especially our food, right?
Yeah.
So we
Yeah.
definitely have seen that.
Yeah, I mean, there's everything there, right? Like, so our environment toxins certainly are, because these are liver, like it's our liver clearing through phase one and phase two is like the main, like the organ that's really clearing these hormones. So any burden on our liver outside of hormones is going to add to kind of how these hormones are metabolized. So environmental toxins, alcohol can have a big impact, pharmaceutical drugs for good and for bad can have an impact on some of those pathways. But then there's certainly foods that can be used to shift things in a positive direction. There's supplements and certain extracts and herbs that can shift things. So, and then there's things that we're always working up against, like genetics as well, that for some people are kind of part of that picture.
Yeah. Joe, do you want to talk about anything?
Yeah, I'd be curious just because it's something I deal with so much all the time. So when we're looking at the Dutch test, you talked about your downstream metabolites. We really look at the 16 hydroxyestrone, the 4 hydroxyestrone, 2
Mhm.
hydroxy, and then obviously the 2 methoxy. I know you mentioned that those metabolites, some are good, some are bad. And just for the listener standpoint, would you mind talking a little bit more about what sort of health disparities may develop from those being in the wrong ratio, or which ones you worry about?
Yeah, so where we want to see, like when we're looking at measuring all those metabolites, you want to see the bulk of your estrogen moving down that 2 hydroxy pathway. It is also still somewhat estrogenic as a phase one metabolite, but it's the one that's the least problematic, is what I say. The 4 hydroxy, that pathway is the one that does come with a potential increased cancer risk. It's a little bit more genotoxic in that it can cause some DNA damage if there's too much of it or it hangs out for too long. And then that 16 hydroxy we were talking about, that one we call more the proliferative pathway. So we see again like growth. So fibroids, it can flare endometriosis, it can like migraines, even mood. It is the most estrogenic of those 3 metabolites. And so we have those phase one acting kind of in that way. And that's then where phase two is important as well. Like we look at how they clear through phase one and obviously want to optimize that. But if they don't move through phase one, any of those, even the preferred 2 hydroxy, can be problematic if it sticks around too long. So you also want to make sure you have good phase two, which I think it was sounding like there was some like issues for Daniela there, where we're talking about like glutathione conjugation, methylation, kind of sulfation sorts of things to inactivate those phase one metabolites.
Mm.
Yep, and that's what we see with a lot of patients, and I think it's interesting. One of the things we've seen a lot is we'll have patients come in maybe from other practices that aren't using the Dutch, and they're like, "Oh, well, I had this going on, so the doc had me take DIM or something,"
Mm-hmm.
and
Mm-hmm.
and I think with that, which heck, it's not like we've never been guilty of that in the past, right? Because sometimes you get into those spaces with patients where you're like, everything looks great. But you have symptom X, Y, and Z. So let's try this, and maybe it works and maybe it doesn't. And without that test, maybe it helps, but it's kind of because like you threw a handful of darts at a dartboard and a couple of them stuck, right?
Yep.
So I know as we've looked at it from a practice standpoint. When we initially started functional medicine, we had hormone patients and we had functional medicine patients, and they were kind of, I don't know, divergent pathways. And we spent the better part, Tiffany and I know, for a year kind of beating our head against a wall, or like they can't exist separately. They just can't, right? Um, because where we see, a lot of our younger female patients with hormone imbalances generally are correctable just with functional medicine, right? With adrenal correction and maybe some things supplementally that help improve hormone synthesis, or maybe steer things like sulfation, or steer the downstream pathways that androstenedione follows, or even
Yep.
how they're metabolizing estrogen and progesterone. But then for our I don't want to say older patients because it's not old, but our later in perimenopause, menopause patients, to a certain extent, they need hormone therapy. But the Dutch is still extremely beneficial because even after menopause, we still see a lot of these patients do have dysfunctional metabolism, where you look at it, like a topical therapy where we're using like a Biest. One of the things we saw a lot with our topical patients, for example, a lot of recommendations were like a 1 to 4 estradiol estriol ratio dosing. But then we see that CYP3A4 pathway super active, where they're just getting overloaded with estriol and then downstream 60 hydroxyestrone. So we're supplementally addressing those pathways, but also changing dosing ratios as well. So, um, and one of the things that I found interesting that we do a lot, because we get into the gut a lot as well. And I know Danielle asked, what sort of things could influence these pathways. We talked about obviously the three mechanisms via the liver. We talked about enzyme activity, which again, they're all the cytochrome 450 family. If you're comfortable, what are some things that you've seen maybe on like the gut end? Because the estrobolome is getting to be a
Oh yeah,
more interesting topic that's coming brought up to me by
sure.
patients, and maybe why that downstream. And I'm sorry I threw an angle in there. Why maybe we're seeing that can even impact the Dutch, and why this works so well within a functional medicine practice that does both.
Yeah, sure. So that's that phase three, right? Like where we've got to get all of these metabolites out of the body, and that's going mostly through the gut, and a little bit like through the kidneys as well. And so having those organs healthy is really important. And part of that is if there's disruption in the estrobolome, or especially like there's high like beta glucuronidase, like certain activity happening, will pull a lot of those estrogens back into circulation. And again, they then add to what you're already producing, and can shift somewhat how we do metabolize some of these estrogens as well. So it plays a huge role. So you want a healthy gut, I mean, for so many reasons, but for healthy detox and healthy estrogen metabolism, that's how all of these things are getting out of your body, right? And you want them to get out appropriately. So that can make a really big difference for sure. Yeah.
Yeah.
Yeah. And there is on the Dutch, like that's one of the other things we haven't really touched on is like we look at these sex hormones and metabolites, but we also have this adrenal panel, but then also the organic acids, which is a nice bonus that you can get in urine. And we do have one gut marker on there. By no means is that like an exhaustive like gut marker, right? Like there's much more comprehensive gut GI testing out there. But it does, when we see that high, there is a correlation with us seeing like higher estrogens a lot of times on the test, and a lot of like likely because they're recirculating and pulling some of those estrogens back into their body.
Yeah. And that's the indicant you're
The
referencing, right?
indican marker. Yep,
Yeah.
exactly. Yep. Yeah, that one we added about a year and a half ago, and it's been, I think, really helpful to kind of have that extra piece of information there.
One of the things I like about that too is now that methylation has gotten so big and such a hot topic in the industry, it's nice with the Dutch because we do see different markers for methylation insufficiency as well. So it's kind of we get to see that a little bit as well, and that always sparks patients' interest. They're like, they're like, oh, I heard Gary Brecka talk about that. And it's like, well, here's the practical application, right?
And that's what we say, like when we're looking at methylation, like we're not testing your genetics because there's actually a lot of genes involved in methylation. We classically think of like the MTHFR gene, right? But that's not what we're specifically looking at the Dutch, but we're looking at like how functionally well does your body methylate these estrogens. That's part of that phase 2, right? So we get to see not just the genetics, but do you have like the precursors and the donors there? Like, are there other things kind of interfering in that system? So we're just seeing like the actual activity. But yeah, it's nice because that one, people know methylation. So it kind of like rings a little bell there.
So really, anyone on hormones at all should do a Dutch test because otherwise, like your serum test isn't gonna give you a clear picture of what your body's doing with the hormones at the
Yeah.
end of the day. And there's
Yeah.
lots of people out there. I'd say the majority of people on hormones probably don't do Dutch testing unless they're going to a facility like this.
Yeah. And, you know, because we look at it as well as obviously we've been doing hormone therapy for a long time. I mean, we've all been in this realm for at least 15 years,
Long time,
right? Yep. Hormone therapy is great. I mean, it's been life-changing for me. It's been life-changing for my wife. It's been life-changing for my family. Obviously, I believe in it. That's why we do it. But we equally believe, if not more so, in functional medicine. But hormone therapy, even bioidentical hormone therapy, uh, if it's not managed appropriately, certainly can have negative effects. And I think for the Dutch test, at least from us, from a practical standpoint, it helps us guide therapy so much more effectively, not only to improve, obviously, efficacy and how a patient feels, but to mitigate any of the potential negative side effects somebody could get. Because, you know, one of the things we've seen too is we've had patients where, you know, their quantitative estrogen values serum are not remarkable. In fact, they look borderline deficient, but they're not having they're not having estrogen deficient symptoms. We pull a test and their estrogen metabolism is extremely poor. And in that case, let's say we were going to go ahead just off serum and throw them on estrogen, we may create estrogenic symptoms, even though their blood level didn't look like that would be a problem because their body handles it so poorly just from a downstream metabolism standpoint. So as far as troubleshooting HRT, I mean, it has become so valuable in our office to the point that we really prefer to have it right out of the gates, but it's also a back end tool where if we have patients that do treatment, that they do labs, that we don't see the improvement we want, we pull that test, and I would say 99% of the time, we can find where the root cause of why that problem's occurring and why that symptom's occurring. And it's, you know, what's funny is all of the things we talked about, obviously it sounds very complicated and it is, but the fixes aren't always that complicated. You know, it's working on this one specific pathway that if we fix this, we're going to resolve these symptoms. And it's, I mean, it's really kind of gives you opens the whole rest of the book for you, you know?
I was gonna ask, when you are fixing these problems,
Yeah.
like you're just looking at their hormones, their bioidentical hormones, and you're adjusting those a little bit. Are you giving them the DIM? What are you doing?
Well, so DIM's used a lot, and again, it helps slow down that CYP3A4 pathway, right? So
Mhm.
if they're making too much 16-hydroxyestrone, that's great. But if they're not, and the problem is down that 4-hydroxy pathway, DIM's not going to do anything. So we may tweak concentrations of hormones based on that Dutch test, or it may be different supplements. So let's say it is that 16-hydroxy pathway that's a problem. Maybe we're doing something like DIM and calcium D-glucarate. DIM to slow down that 16 hydroxy production, CDG to help accelerate clearance. If it's 4-hydroxy, maybe we're using like an injectable glutathione, or we're using N-acetylcysteine. If it's the 2-hydroxy pathway that's bad, well, we know that we need to support methylation, right? So then maybe it's methylglycine, methylated B vitamins, and things like that that are going to serve as cofactors in that process, right? You know, we work on the adrenals as well. We work on that. So a lot of times it's just a few things we're doing supplementally. But if we see that those are off and we see that indicant's high, then generally at that point I say, hey, we're going to work on these things supplementally as well, but we have indication the gut's off. Let's dig deeper into that too, right? And then maybe we pull the trigger on a GI map or something. So
Yeah.
Cool.
I think DIM is an interesting one to talk about because I think that's probably the most common supplement we see providers using to fix like detox pathways or improve estrogen metabolism. And it does when it's appropriate, right? Like, and what it seems to do the most is shift away from that 16 and pulls really heavy down the 2-hydroxy estrone pathway, right? Which is the preferred pathway. But I think the other thing providers don't realize is that it also lowers your parent estrogens because it pulls those estrogens out quite heavily. So the estrone and estradiol. So sometimes when a patient it has poor detox pathways, but maybe already has like decent or even lowish levels of estrogen, you add in DIM and you've almost compounded the problem because you then have lowered their estrogens more. So that's again where testing and not just presuming you know what's happening can be helpful. And that DIM also can sometimes worsen that 4-hydroxy pathway. So knowing how a person is metabolizing things before you just throw a supplement in can be really important. So yeah, that one's always an interesting one to chat with providers about. I love getting to educate them.
It's the one we see the most, especially patients coming in uh, from other practices, but also just on their own. You know,
Oh
and
yeah.
they're like, I heard this was good, and I'm like, well, maybe it may be
My
good.
favorite is always like a postmenopausal patient not on HRT on DIM. And I'm like, you have 0 estrogen. Why are you doing
Yeah, like
that?
that made it worse. Yeah,
Yep. They're like, so the hot flash is still there, huh? Okay. Yeah.
and that's with hormone therapy, our philosophy is always it's 50/50. It's diagnostics and it's subjective symptoms, and we really want to have both. And that's why we love pulling the Dutch in so much, because we always, and I know we've all talked about this on this podcast before, the $1 million question, and you guys get asked it, I get asked it, I'm sure you've been asked it a million times. What supplement should I take? It's like, well, I have no idea. I met you 5 minutes ago. I don't have blood work. I don't have a Dutch. I don't have anything. I don't, it's like, I don't know. Take a handful of pills and throw them into your mouth. Whatever goes in is what you take. So with the Dutch, we like that because it makes everything we do, um, even to an over the counter supplement standpoint, backed on testing. So there's a rationale for everything we do.
Mm-hmm.
Yeah, it's nice because each of those pathways like that we test, like there's a clinical implication and a way like therapeutically to potentially shift that. And for some patients, I mean, most patients just want like a supplement, but there's certainly like a lot of times dietary and lifestyle things that can be done to shift those pathways too. For some of those patients that really are like, I'm taking enough, or I'll only take one thing. It's like, well, if you'll do some diet changes, we can also still work on things. So I know where you can do both, which is always nice. So I like that it gives you options like to treat in a few different ways.
And also another thing is, like maybe somebody has this issue, right, where they're not clearing properly. So is it something that, if they were taking a supplement, they take it forever?
Well, I think that ties into Dr. Brooks' point. The supplements will definitely help correct the issue, but it was dysfunctional for another reason, typically.
Mhm.
So that's where it's like, hey, and I tell a lot of patients most of the time when we do supplements based on the Dutch test, just like adrenals, just like anything else, right? We're using these supplements as a tool to accelerate the reparative process, but we still want to fix the problem,
Mm-hmm.
which
Mhm.
maybe the problem's diet, maybe the problem's lifestyle, maybe the problem's in the GI. So it's like we're going to do this to help correct this more quickly, but we're still going to root cause this thing and correct the other things that are influencing it as well. Because to a certain extent, that's what I'm sure none of us, I don't want to take 30 pills a day for the rest of my life,
Right.
so not that we always
Yeah,
tell people to
there
take
are
them.
Well,
times,
no,
right?
people
Because
do
again,
ask.
some of it's genetics. So
Yeah.
sometimes you're like, oh no, you're just always going to be a poor methylator. We're going to always need to support that pathway, right? But there's some things like again that 16-OH pathway, that 3A4 enzyme, where it's like maybe we need to like gut health has implications there, thyroid. So it's like sometimes you need to optimize some of those underlying issues, and the pathway will correct without the supplementation later on.
Yeah.
Yeah.
Yeah, because people always ask, like, do I have to take this forever? Is this something that I need to do? A lot of people just want a quick fix, is why.
Yeah, a
Yeah.
lot. And that's, it's funny when we get into this, patients are always like, gosh, everything's connected, isn't it? It absolutely is. It
Yeah.
absolutely is. Yeah.
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 Yep.
Okay.
Yeah.
Do you have anything else that you would like to share with us?
I don't think so. You have some more
Okay.
questions or yeah.
You, Joe?
I don't think so. I just gotta say, like, I'm super glad we did this
Yeah.
because I know myself and Tiffany, like, we love this test, and we feel like it's really helped us grow the capability of our HRT practice and improve patient care. So I would say, our three big favorite tools are like the Dutch, ASP with CAR and like a GI map.
Mhm.
So I think really is a, from even, and again, we're pretty heavy into functional medicine as well, but
Mhm.
even somebody doing hormone therapy, having this as a tool at your disposal, even if you don't want to dive all the way down functional medicine, I mean, it just changes your practice and it changes your approach so much. So we
Yeah,
love
and
this
that's
test.
one of the
Yeah.
things I love about working with Dutch. And I don't get to so much get to hear the patient side of it, but I hear from providers how many lives it's changed and what a difference it's made. And I just feel like we're trying to change lives and improve lives, and that's what the test seems to do. So I just love how much it gets to help and how much information, like that's where, like, right, you have the information that gives you the options to change things and improve things long term. So I love that part of it.
Yeah.
Yeah.
We had a patient yesterday just that I met with, and she's been on care with us about 4 months. And uh we worked on the adrenals, we worked on hormone metabolism, we worked on the gut. She's been struggling for 8 years. She's seen a million doctors, all the traditional med routes. She came in yesterday and she's out some tears. She goes, I just want you to know, I feel like I have my life back. I
Mhm.
felt bad for 8 years and I have my life back. I feel good. My mood's good. My energy's great. I'm thinking clearly. My cycles are normal. My gut's better. I mean, you hear that, and again, this is things that we've done with supplement, lifestyle, and dietary modification.
Mhm.
We didn't use a single hormone with her, right? As
Yeah.
Mhm.
far as actual hormone therapy, that was all functional medicine. And that was a combination of, three different diagnostics that aren't traditional medical tests, but it fixed things that traditional medicine has failed to fix for 8 years. So,
That's exciting. I love
I
that.
love hearing, yeah, I love
Yeah.
hearing that. Like, that's
I love
great. And
hearing that
that's
about
with those
people.
like younger women. Like, I love seeing them be able to get back to what their baseline should be without like adding in like hormones. Like, they should be able to cycle normally and have normal lives. Obviously, as we get older and things shift, it's like hormones are needed a little bit more because we're not going to make them, and that can make a huge difference. But yeah, that's an inspiring story for sure.
Yeah, I love that story.
yeah,
Yeah, we need to share more stories like that so
yeah,
people know, because it's a lot of people don't know.
yeah,
And so I love that story. Thank you for
Yeah.
sharing that,
yeah.
Joe.
And that's why we do it, right? Like
Yeah.
you hear that and you're like, okay, this
Hmm.
is,
I know. I always say to people, like, sometimes you just wonder, like, are you changing a life? Like, is anything happening? Like, I haven't heard anything.
yeah,
And then it'll be that one random person that shows up or like messages you, and they're just like, the other day, I always wonder, like, is anyone listening to our podcast? Right? Like, does anyone listen? Is it changing their life? Are they asking themselves, do they feel like shit? Do they have this problem going on? And the other day, like, I was wondering about that because, we're busy. We have busy lives. Like, we work a lot. And I know that it's sometimes tough for us to be here, but it's also very important to me that we bring awareness to people because a lot of people think it's normal to always feel so bad. And I was thinking this in my head, and right then and there, one of our doctors emailed us and he was like, "Hey, I just want to let you know you guys are doing awesome. And I love listening to your podcast. Stop feeling like shit. You guys are helping so many people." And with that being said, then he's like asking us how to help two of his patients. So I just, it's good to hear people's stories
yeah,
because then it's like,
Yeah.
okay, that's why we're still doing this, right?
Yeah.
Yeah,
That's why we do what we do, right? We
right,
want to help people feel better, not feel like shit, have
right.
better lives, and be healthier longer, right? Yeah.
Yeah,
Yep.
right. Yeah, I always tell people you life is like once you hit a certain age, I don't know what it is, but it's like it goes by so fast and you're just trying to live your best life and you're just trying to be healthy while you do it. No one wants to
Mhm.
feel like crud, living in the world that we live in.
Yeah.
So, yeah,
yeah. In the
Yeah.
world that we live in makes it very easy to feel like crud.
right.
Yeah,
That's why I always say
Right.
it's an uphill battle. Like, everything is
Yeah.
working against us in the world we live in. So it's like, how do we right that ship a little bit better?
Yeah. Well, I'm very thankful of your time today. Like I said, I do know that the office loves the Dutch test. We talk about it all the time, and I know that
Awesome.
it's our go-to thing. So I
We love
appreciate your
that.
time. Thank you for being part of our show today. And do you guys have anything to say?
No, thanks. I really
No?
appreciate it.
Yeah.
Oh.
So thank
Yeah,
you so
thanks for
much.
having me. It was
Yeah.
lovely, wonderful chatting with all of you. So thank you so much, and I love that you love the Dutch.